Welcome back, everyone. We're going to talk about natriuretic peptides today. We'll also talk a little bit about acid-base balance, and we're going to work through a problem that helps put everything together. It's going to include some stuff that we've talked about in the cardiovascular section, some stuff that we've talked about in the respiratory section, and a lot of stuff that we've talked about with the kidney. So we'll start off by discussing natriuretic peptides. All natriuresis means is sodium loss. There is a substance that is known as atrial natriuretic peptide that's made in the atrium of the heart. It's created when the atrium stretches more than normal. So it's really related to fluid volume when you have too much fluid volume, and it will be created and released. And when it is released, it leads to more water loss and salt loss. So it really has the opposite effect of things like the renin-angiotensin-aldosterone system. It helps reduce the renin-angiotensin-aldosterone system. It reduces vasopressin release. And both of these are in an attempt to reduce the amount of sodium and the amount of water that is within the blood vessels to help maintain blood pressure. And so here's how it works. If there's an increased blood volume, this will cause increased atrial stretch. The myocardial cells within the atria will release natriuretic peptides. And these natriuretic peptides have a multitude of effects. Number one, they will act on the hypothalamus. And in the hypothalamus, they will cause decreased release of vasopressin. With decreased release of vasopressin, there is decreased water reabsorption at the collecting duct. And so therefore you're going to increase water excretion and decreased overall blood volume. And that'll help decrease blood pressure. At the level of the kidney, it has two effects. The first effect is at the level of the afferent arteriole. The afferent arteriole will dilate with these natriuretic peptides, and this dilation will lead to an increased GFR. That increased glomerular filtration is because more blood is entering the glomerulus, and that increases the hydrostatic pressure of the glomerulus, which increases the net pressure across. And that will cause more fluid to go into the Bowman's capsule and into the nephron. More fluid, more filtrate means more excretion of water and salt. It will also lead to decreased renin production. That decreased renin production is going to have a decreased effect on stimulating the renin-angiotensin-aldosterone system, meaning that you're going to get less of each of those effects. And the main effect of that is really would have been to increase blood pressure, but if you decrease renin, that's going to decrease blood pressure. Natriuretic peptides have a direct effect on the adrenal cortex, and specifically the zona glomerulosa of the adrenal cortex, and you'll get less mineralocorticoid released, less aldosterone, and with less aldosterone, that means that you're going to get an increased excretion of sodium. Finally, the natriuretic peptides act on the medulla oblongata, and this will decrease sympathetic nervous system output. That decreased sympathetic nervous system output means that you're going to get a decreased blood pressure. And that's going to be because of the effect of you're going to decrease the heart rate. You're going to decrease the contractility of the heart. That's going to decrease cardiac output, which is a main player in blood pressure, if you recall from our cardiovascular section. But B, it's also going to cause vasoconstriction of the arterioles, which is going to, that's what the sympathetic nervous system does, but it will decrease vasoconstriction and you will get an overall decreased blood pressure. So medulla oblongata, decreased sympathetic nervous system output, meaning that if you don't have the epinephrine, norepinephrine being released, you're going to get a decreased heart rate, a decreased contractility, and that is going to decrease your cardiac output, which will decrease blood pressure. So we'll try to put it all together now, and we'll see how things work in a multi-system approach. So here's a sample scenario. Sample scenario is Megan's a 44-year-old lady. She's unfortunately become sick with a viral gastritis. She's experienced severe vomiting over the past 24 hours and is unable to eat or drink anything without vomiting. Her sister finds her very lethargic and appearing extremely sick and brings her into the emergency room. So when she's in the emergency room, she's found to be severely dehydrated, and she has a very low blood pressure of 80/32. Her normal is somewhere around 120/80. And so the question is, describe the physiologic compensatory mechanisms that are active in Megan's body right now, given that she has a low blood volume and a low blood pressure. Right now, we're going to disregard any acid-base disturbance that she has from her vomiting. There will be an acid-base disturbance from it, but we'll just disregard it for now. And so this is a multi-system compensatory approach that will be occurring within Megan's body to try to maintain blood pressure and to try to conserve blood volume. There are a lot of volume and osmolarity disturbances that a person can get, and they can actually occur in any combination. You can have a decreased blood volume and decreased osmolarity. You can have an increased blood volume and an increased osmolarity. You can have, and there are certain reasons why people would get each one. So for example, hemorrhage, if somebody's bleeding, they will have a decreased volume, but they're losing whole blood. So their osmolarity is going to be normal. Compared to somebody who is being either given or ingesting salt water that is hypertonic to the osmolarity of the blood, that will actually cause an increased osmolarity and an increased volume if they continuously take it in. Something like dehydration in the form of sweat or diarrhea can lead to a decreased volume with an increased osmolarity. If there's a situation that I'm going to give you on your exam, I will let you know which one it is, whether there's a decreased osmolarity and an increased volume or a decreased osmolarity and a decreased volume. I will let you know which combination it is. I don't expect you to memorize exactly which situation you're going to get each. And so here is what would likely be happening in Megan's body right now. So she has severe dehydration, and this dehydration is going to result in a low blood volume, because she's dehydrated, and a low blood pressure. The very first thing that happens is that there is a cardiovascular response, and it's through the baroreceptors that we've talked about. So these baroreceptors are very quick to respond because it's a nervous system response. In general, anything cardiac or neural is very fast to respond. Anything endocrine is a little bit slower of a response. So that low blood volume, low blood pressure is going to be sensed by the baroreceptors in the carotid and aorta. And that signal of low blood volume and low blood pressure is going to be sent to the medulla, which contains the cardiovascular control center. And it is going to perceive that signal, and it's going to send out a response that is going to try to elevate blood pressure. And it does so by decreasing the parasympathetic nervous output and increasing the sympathetic nervous output. The parasympathetic nervous system is going to have a direct effect on the heart. Specifically, it's going to that decreased parasympathetic output is going to lead to the heart rate to increase. So that heart rate is going to increase, and that's because, if you recall from the cardiovascular section, that the sinoatrial node has muscarinic receptors on it that will bind to acetylcholine. And without that acetylcholine, normally it would lower the heart rate, but with a lower parasympathetic output, you're not going to be able to keep the heart rate low. So your heart rate is going to increase. That increased heart rate is going to effectively help increase your cardiac output. The sympathetic nervous system, as we know, also has an effect on the heart. And it actually has two effects on the heart. The first effect, as we know, it will help increase heart rate. So that increased heart rate is going to be because that norepinephrine that's released from the sympathetic, the increased sympathetic stimulation is going to bind on to those adrenergic receptors on the sinoatrial node, beta-1 adrenergic receptors specifically, and it's going to cause the heart rate to increase. Again, that is going to increase cardiac output, because we know that cardiac output is equal to heart rate times stroke volume. Second, that sympathetic output, the norepinephrine and epinephrine are going to have a direct effect on the cardiac myocytes to increase the force of contraction. And that increased force of contraction is going to lead to an increased stroke volume with every beat. And so it further allows for an increase in cardiac output. That cardiac output, as we know, has a direct effect on blood pressure. So increased cardiac output yields a higher blood pressure. The sympathetic nervous system has a response peripherally to the arterioles. And the majority of your arterioles in your body will undergo vasoconstriction with an increased sympathetic tone or increased sympathetic stimulation. And so that vasoconstriction is going to increase the peripheral resistance. And we know that increased resistance in the arterioles is the other factor that increases blood pressure. And so that's the first thing that's going to happen. It's from the cardiovascular system standpoint, and that's going to help raise blood pressure. The second thing that's going to happen is if this decreased blood volume and decreased blood pressure is accompanied by a higher osmolarity, that you're losing more fluid than you are solute, this high osmolarity is going to be sensed by the hypothalamus. And that hypothalamus, the hypothalamic response, it will be such that it will respond to that high osmolarity because of the osmoreceptors. And as we've learned, high osmolarity is the most potent stimulus for the release of vasopressin or antidiuretic hormone. So that high osmolarity is going to stimulate the hypothalamus to increase vasopressin release or antidiuretic hormone release from the posterior pituitary, which we know will have an effect on the distal nephron, specifically the collecting ducts. And you're going to put in all of those aquaporins into the collecting ducts so that you can reabsorb the water. The reabsorption of water is going to have a twofold approach. Number one, it's going to ensure that you're not losing more volume. You're going to minimize the volume that you're losing. But number two, it's also going to try to minimize any further increase in osmolarity. At the same time, the hypothalamic response to this high osmolarity is to increase thirst. And so that increased thirst will yield a higher water intake. And together, that higher water intake and more water reabsorption will hopefully increase the blood volume. And that increased blood volume will yield a higher blood pressure. Furthermore, that increased water content in the blood will help drive down that osmolarity and bring it back down to normal. So we've seen the cardiovascular response, We've now looked at the hypothalamic response, and now there's the renal response and the renin-angiotensin-aldosterone system, which is also going to be active in this case. And so from the standpoint of that low blood volume and low blood pressure, the main renal mechanisms, number one, is that lower blood volume and blood pressure is going to cause there to be a decreased GFR. Decreased glomerular filtration means that you have less fluid flowing through the kidney per unit time, and you're going to conserve more volume. Secondly, that decreased GFR is going to be sensed by the macula densa. You have decreased flow at the macula densa, and that's going to stimulate the granular cells to produce renin. And if you remember from our renin-angiotensin-aldosterone section, decreased blood pressure also has a direct effect on the granular cells to produce renin. So now we have two inputs that are saying increase renin production. And so we know that renin is going to activate angiotensinogen and cleave it and form angiotensin 1. That's going to travel through the bloodstream. And while it's traveling through the bloodstream, it's going to get converted into angiotensin 2. And that angiotensin 2 has a multitude of effects. And we've learned what those effects are. We know that it is one of the most potent vasoconstrictors. So it's going to cause the arterioles to vasoconstrict. We know that it's going to affect the hypothalamus and pituitary to release more vasopressin. We know that one of the effects is it's going to increase thirst. We know that one of the effects is to stimulate the adrenal cortex. And we know that one of the effects is also to directly stimulate the cardiovascular control center. If you've forgotten what angiotensin 2 does, I encourage you to go through the diagram of what angiotensin 2 does, and you'll see that it's all of these effects, just written in a different format. Now, depending on what the osmolarity is, aldosterone, if osmolarity is too high, you're going to get a decreased aldosterone production and a decreased sodium reabsorption at the level of the nephron. If osmolarity is fine, all of this will be flipped. You will increase aldosterone, increase sodium reabsorption. And so now we can throw more pieces in. So we went from what angiotensin 2 does, but now we have some other effects. And so this is trying to put it all together, that directly the sympathetic nervous system has the direct effect on granular cells to increase renin even more. It has the direct effect in reducing GFR because it vasoconstricts the afferent arteriole more than the efferent arteriole. So there's more constriction of the afferent to reduce GFR. And so all of these effects together are what is going to happen in Megan's body while she has a low blood volume. It starts with, really, the first thing from this diagram is that there is the cardiovascular response to try to improve blood pressure. The next thing that happens is that you're going to get the hypothalamic response. And then the slower of the responses, but it'll still happen, are the renal mechanisms and the renin-angiotensin-aldosterone system. Those are the ones that are a little bit slower to occur. So go through this a few times. Make sure that you understand the concepts of what is going on. You may even choose to review these in terms of the various systems that we're talking about, or the various mechanisms that we're talking about. And see if you can make sense of it, know where all of the stuff comes from. And the end result of all this is to truly try to increase blood pressure And depending on what the osmolarity is, bring that osmolarity back to normal. Those are the end results of all of this. So acid-base balance, we're only going to scratch the surface of acid-base balance. When we talk about acid-base balance, pH is a measurement of the concentration of hydrogen ions or protons in solution. There's only a small amount of change that can actually be tolerated in the body. It's a very, very narrow range. Your textbook will say it can be between 7.38 and 7.42, but truly the normal range of pH is anywhere between 7.35 and 7.45 of your blood. And it's the typical value that is always quoted is 7.4. That is the normal pH in the human body. And so why is a stable pH so important? It's because a change in the hydrogen ion concentration can alter the tertiary structure of proteins. And this can cause proteins and enzymes within the body to denature or to not work as well as they would in a normal pH for the body. And very small changes can affect these proteins. There's a couple of states within the body when pH goes up or down. A situation where pH is too low, specifically if it's talking about low pH, a low pH state in the body, they refer to that as an acidosis. Specifically, if they're only referring to a low pH in the blood, they refer to that as an acidemia. Emia meaning blood and acid meaning the state of. For our purposes, acidemia and acidosis are the same thing. In the case of acidosis, the general effect is that the neurons are going to become less excitable. And what this will lead to is a overall central nervous system depression and disorientation. The opposite state in the body is alkalosis. And if they're talking about a high pH just in the blood, it's referred to as an alkalemia. Again, for our purposes, both of those things are the exact same. We can use them interchangeably for our purposes. In this state, you actually get the opposite. You get neurons being hyperexcitable. And instead of there being that depression, that central nervous system depression, you end up getting a tingling sensation in your nerves because they're getting more excitable. You get sustained muscle contractions because the nerves that are innervating the muscles are firing more. And a lot of acid, where does the acid and base come from in the body? It comes from the intermediates of the citric acid cycle. All of those are acids. It comes from amino acids. It comes from anaerobic respiration, where you produce lactic acid. And it can also come from the breakdown of fatty acids, whereby a person can make keto acids. By far, the majority of your acid actually comes from carbon dioxide. And it's interesting because carbon dioxide doesn't even contain a hydrogen ion, or a hydrogen atom, but it is the biggest source of acid in the body. And it has to do with this equation. Carbon dioxide plus water yields carbonic acid, and then that carbonic acid dissociates into a hydrogen ion and a bicarbonate ion. This is all occurring in the presence of carbonic anhydrase, which is that enzyme that will catalyze both the forward and the reverse reaction. And so if we have to maintain a pH within such a narrow range, the main way that we maintain pH, even though we're being bombarded with all of these exogenous or these acids that are being produced in our body, we maintain pH with three mechanisms. The first mechanism, and this is the quickest response because it is a chemical response, we can maintain pH using a buffer system. So a buffer system in chemistry is just a system of molecules that in solution that will resist big changes in pH. And we have multiple buffers in our body. We're really only going to talk about one and a little bit of another one. We're going to briefly mention another one. The second way that we can maintain pH homeostasis is through ventilation. Ventilation, if you think about it, while you're breathing faster means that you're getting rid of more carbon dioxide, which is the most common source of acid in our body. If you breathe slower, you're keeping more carbon dioxide, which will produce more acid. So changing the ventilation rate can help maintain pH homeostasis. The third way is through a renal regulation of pH. So we can regulate the amount of hydrogen ions that are reabsorbed and secreted in our kidney. We can regulate the amount of bicarbonate ions that are reabsorbed and secreted in the kidney. This is the slowest response. The kidney tends to have a slower response, but it's better at fine tuning. It just takes longer. We'll talk about each of these. The main buffer system in our body is the bicarbonate buffer system. And specifically, it's bicarbonate with carbonic acid. This system is the buffer system, bicarbonate and carbonic acid. And large amounts of bicarbonate are produced from carbon dioxide. And it's interesting because we said that carbon dioxide is the main source of acid, but at the same time, we're producing a buffer that can get rid of that acid. And so it appears that this proton and this bicarbonate that can actually buffer this acid are produced in a 1-to-1 ratio. And so the question really becomes, why don't they just cancel each other out? Well, there's a good reason for that. They don't cancel each other out for two reasons. Number one, when this reaction occurs, the proton from this reaction can bind on to hemoglobin. So if you remember from our carbon dioxide transport, this proton will bind to hemoglobin, meaning that this bicarbonate ion is now available to buffer hydrogen ions from other sources, whether that happens to be from lactate or from the citric acid cycle or an amino acid, or whether it's from an exogenous acid, like a medication that tends to be acidic. The second reason why they don't just cancel each other out is that if we add carbon dioxide to this system, it drives the reaction to the right. And there's going to be both more hydrogen ions and there's going to be more bicarbonate. This reaction got driven to the right because of the increased carbon dioxide. If we were to just recombine these, it would push the reaction back. But the reaction has already been pushed into the rightward direction. And so this bicarbonate cannot buffer the hydrogen ion that came from the carbon dioxide reaction. It can't. This bicarbonate can go buffer a different acid, but it can't buffer the acid that was produced from this reaction. So overall, if we have a higher carbon dioxide concentration in our blood, that is going to effectively increase the amount of hydrogen ions that we have in solution, and that's going to cause our pH to decrease. And so if we take it from another perspective, what would happen if we add hydrogen ions? They didn't come from carbon dioxide. We'll say that this hydrogen ion came from some amino acids or some lactate. If we add hydrogen ions to the system, because these hydrogen ions didn't come from the reaction between carbon dioxide and water, the bicarbonate ion can buffer that acid. and it will combine with this proton to push the reaction in the leftward direction. And when you push the reaction into the leftward direction, it will produce more water, which is fine. Our bodies are made up mostly of water, and it's going to produce more carbon dioxide. And this will occur until the system reaches equilibrium. And this is good. This is good because that higher carbon dioxide can now be breathed out by our lungs. And so that brings us to our second concept within acids and bases. It's still a fast response, but it's slower than the buffer system. The ventilation response, as in terms of acid-base regulation. So we can have changes in ventilation that can help correct an acid-base disturbance. We can also have changes in our ventilation that can cause an acid-base disturbance. But let's say, assume for example, that we have extra hydrogen ions. These extra hydrogen ions are going to be buffered by this bicarbonate, and it's going to push the reaction to the left, which we saw on the previous slide. This is going to lead to a higher carbon dioxide level. And this higher carbon dioxide level is going to stimulate the peripheral chemoreceptors to help increase ventilation. And that increased ventilation, the depth of breathing and the frequency of breathing. So we're going to be able to exhale more CO2 to help get rid of those extra hydrogen ions in solution. A couple of examples. So here's an example of how a ventilation disturbance can cause an acid-base problem. So let's say, for example, we are in the state of hypoventilation, where we're not breathing in enough. That hypoventilation also means that we're not breathing out as much carbon dioxide. So that decreased carbon dioxide elimination, that's going to accumulate in our blood. And it's going to drive the reaction to the right. It's going to cause more hydrogen ions in solution. It's also going to make more bicarbonate, but these can't buffer each other because this reaction was pushed to the right because of increased carbon dioxide. So you can't buffer hydrogen ions that came from an increase in carbon dioxide. Because these ions are now in solution and you have more hydrogen ions in solution, this is going to decrease the pH of the blood, and you're going to be in a state of acidosis or acidemia. This exact example is considered a respiratory acidosis, and it's specifically because the disturbance was created because of a problem with the lungs. So they call this a respiratory acidosis. And this can happen for a number of reasons, where somebody hypoventilates. It could be through medications. The most notable medication that will cause hypoventilation are opioid medications or narcotic medications in the family of morphine. So morphine, Percocet, hydrocodone, fentanyl, carfentanil, Dilaudid, all of those are within the category of morphine-related drugs, and they can lead to hypoventilation. And that can cause a respiratory acidosis. Another example is, imagine we have the exact opposite situation where we're hyperventilating. More air is being breathed out per minute. And this may happen in the case of a panic attack where somebody starts breathing faster. The carbon dioxide level is going to go down. You're breathing more carbon dioxide out. And as a result, the reaction is going to be pushed to the left to try to replenish that carbon dioxide and get it back to equilibrium. In the process of doing so, you're reducing the hydrogen ions that you have in solution. And a reduction in hydrogen ions in solution means a higher pH or a state of alkalosis. Because this was created due to a problem with the respiratory system, they call this a respiratory alkalosis. There are two other forms of acidosis and alkalosis. They're called metabolic alkalosis and acidosis. We're not going to get into those right now, but know that they exist. The third way that we regulate pH is through the kidneys. And the kidneys will help deal with the compensation of pH that the lungs can't handle. And there's really two ways of regulating pH. You can either reabsorb hydrogen ions, or you can change the rate of bicarbonate excretion or reabsorption. And this will help fine-tune the pH back to normal. And this happens through two types of cells. There is the first type is a type A intercalated cell. They tend to be in the collecting duct, and they deal with acidosis. That's how I remember it. They deal with acid, an increase in acid, an acid state in the body. I know that the other word is alkalosis, but just wait, there's a way to remember it. Type A intercalated cells, the A stands for acid. So it deals with acidic states. And this type of cell is going to allow for the excretion of protons, while at the same time you are increasing the reabsorption of bicarbonate and the reabsorption of potassium. So let's have a look at the type A intercalated cell. So we're in the nephron right now, and so this yellow area is the lumen of the collecting duct. The blue region, this is the cell, and the purple region, that's the interstitial space, and the blood is the red region. So imagine that you have a state of high levels of acid in the body. So you have a high hydrogen ion concentration. In the interstitial space, those hydrogen ions are going to combine with a bicarbonate ion. And that's going to produce both water, which isn't listed here. Water is often just assumed to be available, or if sometimes they don't write it in. And it also produces carbon dioxide. And this carbon dioxide is going to diffuse into the cell. Well, when it's in the cell, it combines with a water molecule, and via carbonic anhydrase, it's going to make carbonic acid, and it's going to be split into a proton and a bicarbonate ion. Those protons are going to be actively pumped out of the cell and into the lumen so that they can be excreted in the urine. And there's two pumps that do this. There is a proton pump, which is just pumping protons out. And there is a proton potassium exchanging pump, where there is a proton that is being pumped out and a potassium ion that is being pumped in. The end result of that is that you're going to get an increased H+ or proton concentration in the urine. That bicarbonate that you created within the cell is going to be pumped out on the interstitial side of the cell, and it's going to be using a bicarb chloride exchanger. So that bicarb is going to be transported out of the cell, and it's going to be an exchange for a chloride ion. The chloride ion is going to enter the cell. That bicarb is going to be used to buffer more hydrogen ions, and the cycle will continue until you reach equilibrium. This potassium is going to be reabsorbed. So people who have a state of acidosis often have a high level of potassium in their blood. And that high level of potassium we know can be dangerous, as we learned from our when we talked about aldosterone receptor blockers. Type B intercalated cells. So if there's a type A intercalated cell, there's got to be a type B intercalated cell. And so the way I remember type B intercalated cells is that they deal with a disturbance that deals with base. base or alkaline disorders. So A is acid, B is base. Type B intercalated cells deal with base problems. And again, they are located in the collecting duct, and they deal with alkalosis. And they do the opposite. They reabsorb hydrogen ions and they excrete bicarbonate ions so that you can replace those hydrogen ions and bring the pH back down to normal. And it actually looks very similar, but it's flipped. So the first thing that you'll notice is that all of the exchangers in the pumps are on opposite sides, but everything else looks to be similar. The interstitial space is going to have a low hydrogen ion concentration because we're in an alkalotic state. This type B intercalated cell is going to, there's going to be a reaction between water and carbon dioxide, and it's going to create a bicarbonate ion and a hydrogen ion. This bicarbonate ion is going to be transported out of the cell on the luminal side, and so the bicarb can get excreted in the urine. This is going to be in exchange for a chloride anion. So that chloride anion is going to enter the cell. At the same time, that hydrogen ion is going to be pumped out, actively pumped out of the type B intercalated cell by the H plus ATPase and the H plus K plus ATPase. Together, that is going to allow for hydrogen ions to be reabsorbed in the blood and bring pH back to normal. That potassium that is being pumped, the potassium is going to be pumped in, and that potassium is actually going to be excreted in the urine. So somebody who's in a state of alkalosis will sometimes have a low potassium level. So their potassium can go down. Low potassium can be dangerous, just like high potassium. So let's get back to Megan. She's been sick with her viral gastritis. She's been vomiting for 24 hours. We already understand how her body's been dealing with the dehydration and the low blood volume and low blood pressure, but she has an acid-base disturbance. And so would you expect her to have a problem with pH from vomiting? The answer is yes. Imagine somebody is vomiting. One of the things that is created by the stomach is hydrochloric acid. So if somebody is vomiting out a bunch of hydrogen ions from their body, you're going to be in a state where you're going to become alkalotic, or you're going to go into a state of alkalosis. And so how her body would deal with this acid-base disturbance is that it's going to deal with it, yes, with the buffer. It's going to be, yes, we're going to use the ventilation, but she's losing that acid secretion. And so number one, that decrease in H plus is going to be buffered. So it's going to drive the reaction to the left. Actually, it's going to drive the reaction to the right, and our CO2 is going to go down because we have a lower H plus. So we're going to drive the reaction to the right. And a lower CO2 is going to mean that her respiratory rate, she may not be breathing as deeply or as rapidly because of a lower CO2. The renal compensation for this change that we talked about will be in the form of a type B intercalated cell. The type B intercalated cell is going to help bring hydrogen ions back into the blood. And it's going to help get rid of the bicarbonate ions so that they're excreted in the urine. And so what would you expect Megan's potassium concentration to be? High, low, or normal? So if we look at what the type B intercalated cell is doing, the type B intercalated cell is going to, yes, reabsorb protons, but at the same time, it's going to secrete potassium ions. So potassium is going to be lost in the urine, and potassium levels should be low. And it's because of those type B intercalated cells that they're getting secreted in exchange to bring pH back to normal.